Okay, today's feature presentation, I'd like to turn this over to Charlie real quick to introduce Thomas and tell us about what brings him here today.
Thank you. Thomas and I met at a meth and opiate board or working group that we were part of a few years ago. He now works at the Open Door Mobile Health Services, the Telehealth and Visiting Specialist Center, and the Open Door downtown clinics of Open Door Community Health Centers, a federally qualified health center serving over 44% of the population of Humboldt and Del Norte counties in rural Northern California. Open Door downtown, it is the Eureka location of Open Door's Medicated Assisted Treatment services. Thomas himself is a recovering addict and alcoholic, began his career in healthcare as a certified medical assistant. He was attracted to the core values of dignity and service that are the hallmark of the culture and mission at Open Door Community Health Centers. During his career, he had the opportunity to grow and work in multiple departments and clinic sites throughout the Open Door system, both at the patient care and operational levels. They had the privilege to assist and lead on multiple projects that have enhanced care in both clinical systems and within the community, often working in partnership with other service providers and organizations across the continuum of care. Thomas is a graduate of the Clinic Leadership Institute at UCSF, the Center for Health Professionals. Among his many roles at Open Door, he's worked as a leader in the ongoing development of Open Door's response to addiction to opioids across the community, currently manages the Open Door Medical Assisted Treatment Services in Eureka. One of the quotes that he enjoys is, "The opportunity to carry water and serve those who care for our most vulnerable neighbors is what brings me back every day." Thank you.
Okay, so I'm assuming I'm on. Thank you, Crystal. Listening to that bio, I realized when you send professional bios for things like this, it's a little bit schmarmy. I probably could have done something a little bit better. But again, I'm Thomas Steenblock. I've worked for Open Door now for 14 years. I've been in recovery for 15. Just so folks know, yes, I'm a recovering alcoholic and addict. I actually recovered from narcotics addiction back in the day before there was medication assisted treatment. I didn't learn any of those behaviors at home. Unlike many of my fellow alcoholics and addicts, I actually come from a home of loving, kind, well-educated, well-to-do folks who set healthy boundaries and told me that I mattered and all that kind of thing. And for some reason, I never bought into any of that. And I grew up in the 70s and did the things that kids in the 70s were doing, and all of them went on and had lives, and I went on to do what I went on to do. But fortunately, I found my way into recovery and into a completely new life. And with that, I'm really grateful to be able to be here today and talk to you guys about this topic. It's amazing to be here with the Rotary, your service in the community, and often unheralded and unpraised for all the work that you do in the background, making the world and the community a better place, is a real credit to all of you. And it's nice to be able to talk to you about that. I'm going to attempt to share my screen here. Zoom is always a little hinky, so sometimes when I do it, I can't tell if it's sharing it or not. So let's see. I want to get the right one. Where did it go? Here we go. Hopefully, can you see slides? Okay, great. Now we'll see if they move while I talk. So you heard a little, and is it going to go? And it's not going to go for me. Oh, there we go. Okay. So real quick, just about Open Door, you heard a little bit about it. For those of you who aren't that familiar with us, we're a federally qualified health center. We were first founded in 1971, so they've been a big part of the community for a really long time. Their very first clinic, when they had a clinic with 14 volunteers, was right there in Arcata in what is now the Tin Can Mailman. We actually serve all of Humboldt and Del Norte counties. And that is an area that's larger than the state of Connecticut. And so it's really interesting to think about, we live in this region up here, and I don't think many of us appreciate how vast it is compared to some complete states, and we're just a couple little counties together. We have 11 clinics across that area, and over any given 3-year period, we serve roughly 90,000 unique individuals. So that's a really good portion out of the 160,000 in total that live between the two counties. And we offer a full range of services, including family medicine, behavioral and mental health, case management, drug and alcohol services, and much more than that. And along with that, you know, really why we're here to talk today is about medication assisted treatment, but to even be able to talk about that, we've all heard the word addiction. We all understand that it's an issue in our community. It's often in the news and that kind of thing, but what is addiction really? And so some of you may know this stuff and some of you may not. So bear with me while we just lay just a little bit of a framework for discussing this today. And addiction, you know, here you can see a definition from the American Society of Addiction Medicine, which is a medical society that it sets up basically the standard of care for doing particularly medication assisted treatment. And it talks about addiction as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and individual life experiences. And that people engage in compulsive behaviors that often continue despite harmful consequences. The bottom line is that addiction is complicated. Why some people do stuff and end up being addicts or alcoholics and why others do it and do not, there's a lot to that and a lot to unpack. The more important thing is what can we do about it? And what's notable is the prevention and efforts at treatment for addiction are generally as successful as those for other chronic diseases. And this is a thing that people don't often think about. And this is why we talk about addiction as a disease, because what we see is very similar outcomes. And to compare it, here we go. Diabetes. Patients who relapse. What do we mean by relapse? We mean that they stop treatment and they go back to how it was and suffer the consequences of their disease. Type 1 diabetes, and this actually goes even more so for type 2 diabetes, the percentage is higher. 30 to 50% of people go off their treatment, go back to their old habits, and suffer from their disease. Hypertension, 50 to 70% of people go off their regimen, go back to their old habits, and suffer the consequences of their disease. Asthma, 50 to 70% as well. And this tells us some things about this. It tells us that, and if you look at drug addiction, 40 to 60% of people relapse and go back. And that means that a lot of things in healthcare, most of healthcare is really about behavior. We can give you all the right medicines and all the right education, but none of that changes unless you can change from within. And that touches back on the really complex roots of why people have addiction in the first place. And particularly today, we're here to talk about opioids and their consequences. Because when we talk about medication-assisted treatment right now, the core of medication-assisted treatment is for those who suffer from addiction to opioids. We hear about this a lot in the news here locally in Humboldt County. What are opioids? And, you know, so opioids are any drugs that are either derived from opium or are synthetic drugs made by man that are like opium. And that includes things like heroin, synthetic opioids that are big in the news right now, like fentanyl, that has been causing so many overdoses and challenges across the United States, as well as painkillers that are legally prescribed by doctors, including OxyContin, Vicodin, Norco, codeine, morphine, and many others. And in fact, I can tell you that nearly half of the folks that we see with opioid addiction started their journey with a prescription from a provider for a legitimate medical condition. And it began there and then went on. And when you're on opioids, you know, people using them for short runs generally don't have a problem. Using them for a long time can cause something, you know, physical dependence. And what are we talking about there? Well, we're talking about when you don't have the medication, you go through some withdrawals. And withdrawals are not a comfortable experience. I know this from my personal experience myself. It is nausea and vomiting, diarrhea, insomnia. They'll have anxiety. They'll have increased body temperature. They'll feel blazing hot, and then they will begin to shiver and feel incredibly cold. Racing heart rate, and in fact, heart rates can sometimes go so high as to cause heart problems, muscle and bone pain, sweating, chills, and elevated blood pressure. In fact, withdrawal, if you think of the worst time you ever had the flu, where you really almost thought you were going to die or you wished you would die so it would just stop, that's more or less the experience that most narcotics addicts have when they suffer withdrawal, if they've been using for any significant amount of time. And so what we're really talking about here is addiction to narcotics, to opioids, and how it impacts things. And so does everybody who uses these drugs become addicted? and suffer the problems that we see in society that lead to crime, that lead to problems at home, that lead to loss of health, loss of life, overdose, and death? And the answer is actually no. And in fact, we learned something really interesting from the folks that served in Vietnam. There was multiple studies done on this. The military actually shows a higher percentage rate than is even indicated here, but this is considered to be one of the best done studies. And they actually showed very, very high rates of heroin use, up to 34%, and symptoms of dependence among at least 20% of US soldiers while they were serving in Vietnam. So they're there for a few years, they're using heroin for a few years, they're showing signs of dependence. When they return to the United States, only 1% of them, following up over the next 10 to 20 years, only 1% became re-addicted to heroin. And about 10% tried it when they got home and then decided, nope, that ain't for me. Now, how is that? Heroin is one of the most addictive substances known to man. It definitely can cause physical dependence, withdrawal, with all of the symptoms that we named. And it comes back to those complex issues and things that make someone an addict. Physical dependence is part of it, but there's things that are more. And what we've come to learn over time is that the psychological situation for that person, especially at the time that they're using, the economic situation for that person, genetic components, there are genes that tend to indicate people have a higher probability of becoming addicted to certain substances. And their social settings, all of those can impact that. And one of the things that we know impacts it the most is a history of trauma. When people have experienced challenging life situations, they are more prone to addiction. And this includes things like childhood abuse, witnessing a murder, witnessing a death, and so on. So why is it so bad in Humboldt? Our rate's 3 times the rest of the state for overdoses. We have one of the highest rates in the state, and the state has one of the highest rates in the country, so that puts us in a pretty bad place. And there's a number of things that contribute to this. Things like how isolated the area is and how isolated people can often feel. Geographic distances contribute to transportation barriers and accesses to service. Community acceptance and tolerance of heavy drinking and drug misuse. This area, amongst at least some people, has a reputation for this, and people kind of buy into that. And then adverse childhood experiences and trauma are associated with substance use disorders. And when they do surveys, people rate very, very high on the scale of having previous traumatic events in our area compared to other locations in California. So what's medication-assisted treatment and why should we do it? Well, medication-assisted treatment is the use of medications in combination with counseling and other stuff to help provide a whole person approach to treatment of substance use disorder. When comparing counseling alone to counseling plus medication for treating heroin addicts and addicts of opioids, the relapse rate is 40% higher for those who are doing counseling alone than those who have counseling and medication. The two together provide a stronger base. The medications are designed to help reduce the withdrawal symptoms without causing the mental changes and all of the other things. The other thing is when they're getting this medication, they're taking care of it, because the reason addicts do a lot of what they do, the crimes and the various things, is because they don't want to be sick. They desperately don't want to be sick. It feels so horrible, and they will do whatever to avoid being sick. And so they commit many of the acts that they do. They don't feel good about it. Many of the folks that we talk to, I can tell you, they don't like the life that they're living, but they feel stuck because every time they stop, they get desperately ill. And so they fight to keep themselves there. And when we go ahead and we take that off the table, we take the withdrawal symptoms off the table and begin to work with them on the reasons that they use, many, many more people are able to stay in the recovery services and begin to move forward. And the goal here is to improve patient survival. Without treatment, 8 to 9 out of every 10 opioid addicts will die from the disease directly. They will die from overdose or other complications, heart disease and other things related to it. And that has proved really consistent over time. Intervention lowers that somewhat. It also helps increase retention and retreatment. As I said, fewer people relapse when they have medication along with the counseling. Decrease illicit opiate use and other criminal activity. And that's one of the big things about this. This is what's called a harm reduction strategy. When people are on medication-assisted treatment and they're regularly getting this medication, guess what? They don't need to go roll somebody for their wallet to go ahead and get their next fix. They don't need to work all the time to be focused on that and to commit crimes in order to be able to do it. It also increases their ability to gain and maintain employment. And we've seen that success story in our program so many times. People getting jobs, people being reunited with their children, people being reunited with their families, improved birth outcomes for women who have substance use disorders. If a mother is on Suboxone during her pregnancy, her baby will not be born addicted to opioids. We can change the game. Instead of bringing babies into the world that are addicted to heroin, we have a mom who's in recovery, getting counseling, getting services, getting support, and a baby that's born free of addiction. It makes a huge difference in that baby's life and whether they may or may not turn out to be an addict later in life. So, and another really big reason to be doing this, every dollar invested in addiction treatment programs yields between $4 to $7 in reduced crime, criminal justice costs, and theft. If you add it to healthcare costs, every dollar invested can bring back up to $12 in saved healthcare costs, which we all ultimately pay for. And so that can make a huge difference in the community in which it happens. The communities that invest more in addiction services pay less on a whole mess of other fronts, and it's been demonstrated over and over again, and the data is out there to look at. So how are we doing this at Open Door? Well, roughly 650 patients in active care for MAT at any time. That's down from 800 pre-COVID. COVID had a really huge impact. Part of the way that you really do addiction services and addicts, it is a disease often titled the disease of loneliness. The sense of isolation that addicts and alcoholics actually suffer is really immense, even amongst people. And so group and being able to interact personally with people is a huge part of recovery. And that was something we were very challenged to deliver during the worst of COVID. We had 1,165 patients receiving those services from us during 2020 alone. And those are the people who were willing to seek services, not all the people who suffer from this problem. And it's embedded in primary care, so we connect people also to get the rest of their healthcare taken care of. We focus on group counseling, education, and support, so the group is the core part of the model, where they're able to check in with drug and alcohol counselors, support each other, learn new tools for living, learn new ways to deal with stress and pain and trauma. On top of that, it has multiple tiers. So there's levels coming in for the person who's really new and very raw coming in. We're trying to just get them on the medication, get them started, get them feeling a little more stable, begin to connect them with services, make sure they have housing and so on. And then there are tiers going on to people who just check in with their provider for their refill, make sure things are going good, who have often developed very full, rich lives. And patients play a role in supporting each other, and that is a very core piece of it, is that shared experience. Sometimes, and I can say this, nothing that I've ever been told in recovery for myself, the tools that helped me grow as a human being, were things that I'd never heard before, but it was different when I heard them from someone who had been through what I had been through. And we've all had those experiences where when we know someone has been through a similar life experience, what they say to us is more meaningful. It hits home. And so that's one of the tools that we use to really help create the sense of community amongst the people that are in our programs. And it's part of a spectrum of care across the community, working with multiple partners. So that's kind of what we do. They really come in weekly in the beginning, and then the frequency is based on their need and a number of other factors. They meet with our drug and alcohol counselors. They meet with a primary medical provider who checks in with them physically to see how they're doing and to renew the prescription. And then we connect them over the longer haul to behavioral health, to counseling for trauma and for the other reasons that led them to use, and then to services. To help them begin to build a new life, to be reunited with families. So there's a very quick thing. I know the time is short. Is there any questions or things that I can offer to anyone?
Thank you, Thomas. Does anybody have any questions from the room? I had one briefly. Go ahead, Charlie.
Oh, one of my questions, I guess, and this is primarily because I have certain clientele. I know that the treatments right now are for like opioids. What about amphetamines? Are there local amphetamine kind of like medical assisted treatments locally yet?
There is not yet. There is experimental testing of a few medications for methamphetamine. So drugs work on very different parts of the brain and in very different ways. And in order to treat withdrawal from opioids, you basically just need something that goes in and plugs in the little receptor in the brain and blocks that up. Whereas with methamphetamine, you're trying to treat some different problems. So they have been experimenting with a drug called naltrexone, which is also used sometimes to treat alcoholism and sometimes to treat opioid use disorder. There's been some small success, but there are experimental drugs coming down, and they're hoping very much to have a medication-assisted treatment for methamphetamine soon. Right now, the number one frontline thing for methamphetamine is still counseling and social supports.
Great, thank you.
Thomas, is there a common thread for people who make the decision to come and seek out help? You know, what is there a point that is similar in most people that gets them to come in your door?
You know, this is the funny thing, and we talk about this in both in recovery and in addiction services circles a lot. The bottom for everybody is kind of unique. What constitutes a bottom for some people, it's not the I don't have a home, I don't have a car, they live like that for years. It's usually a turning point within the person where they can't stand it anymore. That's the bottom line. It's not even fear of death for many of them because they face that so much. And if you are an addict for any amount of time, you lose people to it. You know that you know where the life is going to end you. And for many people, they still persist, but somehow they reach a point where it is just not tolerable anymore to be who they are. And they don't know how to move forward, and they become open to it. The other thing is I think people reach the end of their rope where they simply can't get any more substances. They've been cut off because they just, their dealers are tired of them. They don't have any money, whatever. And they face continued sickness over and over with very little relief. And that physical sensation of being ill sometimes drives them in, and that's the beginning.
I have another question.
Yes.
I guess locally, community, or I don't know, institutionally wise, or for our community, what is one of the barriers that you see for Open Door being able to provide services that our community needs?
We've been very fortunate. I feel, Open Door is really well supported by this community, and, but I think one of the largest barriers is there's just not enough of us versus the size of the problem. And I think we need even greater level of community partners, the adding of partners like Aegis and Waterfront Recovery Services. The more variety of services, the more different methods that are used, the more different avenues there are in a community, the more people enter and stay in recovery. Different approaches work for different people. I'd say the one common thing that the community could do is show compassion and support, because the thing that ultimately brought me around and that welcomed me into recovery was that instead of judging me, people wanted to help me. And when the judgment goes away, the doors open up. That's one of the things that keeps people out of recovery and not engaging with us, is fear of bias and discrimination because they're addicts. They're afraid to even tell people. We have a lot of contention in our community over that. If we can begin to encourage our friends, our neighbors, and our families to recognize, because I can tell you, the people who are addicts in our communities, they are our friends, our neighbors, and our families. And sometimes we don't even know it. Many people can maintain an addiction with a really good front on it. It could be happening to someone we know. And so being willing to be compassionate, understanding, and recognize that addiction is not a moral problem. It's a medical problem. And I think that would be the biggest thing the community could do to clear barriers, is to simply work on that bias and prejudice against it.
You're on mute.
Muted, Ian.
Thank you, Thomas. That's fantastic advice. And I think everybody here can take that into our communities and our daily lives, because it is all around us. Everyone, I apologize, we're a little bit over time, but I think it's worthwhile. And, sometimes there's just more to hear. So thanks for bearing with us. And Thomas, I wanted you to know that our club, in your name and in your honor for presenting here today, is making a donation to the Wheelchair Foundation, which provides wheelchair access to people that could not otherwise afford it. And I have an anecdotal gratitude to give to Open Door. I grew up out in Maple Creek in the hills with effectively back to the land parents, and we were not of means to afford medical care. You know, basically it was a trip to the hospital or just figure it out and be okay. So when I had a significant sinus infection and it became clear that was the issue, my parents gave me some of the penicillin that we used for the sheep and rabbits, and discovered swiftly that I was allergic to penicillin. So that was, I think, 1974. And we didn't have the means to go to the emergency room. So, and Open Door was there in Arcata. So they drove us down from the hills, and Open Door had open doors for that kind of care for people that, you know, really didn't have the means to have insurance or afford an emergency room visit. And so Open Door is and has been for a very long time a great resource in the community, and is clearly, through your team's efforts, addressing a desperate need in the community to heal and recover. So thank you very much.